Okay. Hi, everyone. My name is Dr. Christine Gould, and I'm a gynecologist at Gynecology Associates Gwinnett in Lawrenceville, Georgia. Typically, I host several seminars each year to educate our patients. However, COVID has prevented that with shelter at home. So I decided to have a webinar. And May is Melanoma Awareness Month. So I've asked Dr. Jing Gill for North Georgia Dermatology. Hi, Jing. How are you?
Hi.
Help us talk about melanoma and also some sunscreens. She has dedicated her practice to the surgical management of skin cancer, mainly Mohs surgeries.
Yeah, so first off, I wanted to just present some statistics because people actually, don't necessarily know how very bad it is in our country, especially. So melanoma is actually the most serious form of skin cancer, but it's actually the third most common type of skin cancer. So it's third to basal cell carcinoma and squamous cell carcinomas. But it is something that affects all of us. Melanoma affects even young people, and it's the leading cause of cancer death in women aged 25 to 30. And in the age group of 30 to 35, it is the second leading cause of cancer death. So it's pretty significant. And it's also estimated that in this country, in the U.S., one person dies of melanoma every hour, accounting for approximately 10,000 deaths per year. So melanoma, it's just crazy. It can develop anywhere on your body, including even the non-sun exposed areas. It can affect anyone of any skin color as well. So for me, to treat melanoma, I think the key to treating it is to get it diagnosed early. And as you can see on this first slide, the most important prognostic factor is the depth of the melanoma's extension into the skin, which is called the Breslow's depth. And the deeper the melanoma cells go, the more likely they can invade into the underlying lymph nodes and blood vessels, the very important structures that can carry those cells throughout our body. And it can be very aggressive because it spreads both lymphatically as well as through the blood. So thankfully, the most common melanomas we see today are the most early stages because people are more and more aware of this cancer. And the most early stage is called the in situ stage or stage 0, and it's got very limited depth of invasion. And in these cases, the treatment is a simple surgical excision. There's really no need for any additional diagnostic testing, no need for x-rays or lab tests. But if a melanoma is not caught early and it spreads deeper into the skin, then there are additional tests that we need to do, such as lymph node sampling. And that's usually done with a general surgeon.
Okay.
And that's something called a sentinel lymph node biopsy, which, I think is a little beyond the scope of our talk. So the next slide, you can see, these stages of melanoma kind of presented here. Obviously, the most melanomas that I treat are the stage 0, stage 1 melanomas. And then anything advanced would be sent to the general surgeon or the melanoma clinic at Emory.
Okay.
So yeah, the next slide shows some examples of the 4 main types of melanoma. The superficial spreading melanoma is actually the most common type, and it can rise by itself, like a brand new mole, spontaneously, or it can be a changing mole or a pre-existing mole. And in men, actually, we see most of these on the back, but in women, we actually see a lot of these types of cancers on the legs, because if you think about it, you go out, you lay out in the sun, and most people put sunscreen on their faces and, the exposed areas and forget about their legs. And then the other kinds, nodular, we see a lot of these as well. Lentigo maligna, that's actually more common on the head and neck of older individuals and almost exclusively sun-exposed areas. And then number 4, the acrolentiginous type is actually the least common. It's the rarest form, and it's usually diagnosed a little bit later. So it actually does tend to be more aggressive because of that. And it's usually seen in people with darker skin.
Okay. So Dr. Gill, I'm sorry, I didn't mean to interrupt.
Okay.
So what puts us at risk, Dr. Gill, from all of this?
Right. So if you think about the person that is most at risk for any kind of skin cancer, including melanoma, is obviously somebody who burns easily, who has really fair skin, who's got red hair or blonde hair, light colored eyes, green or blue eyes, and has a lot of freckles and moles. And this person, may always may have been exposed to the sun significantly, may have a job that works outdoors, or doesn't put a lot of sunscreen on. Could be a young person that goes tanning a lot to the tanning beds as well, and also someone who has a family history of melanoma. So all of those things kind of in congruence can increase someone's risk of melanoma significantly. So we know that in people that have many existing moles, especially those who have what's called dysplastic nevi or atypical nevi, they're at significantly higher risk as well. So the next slide actually shows the picture of someone who has a lot of these atypical nevi on their body. And even if they don't have a family history of melanoma, they do have a significantly increased risk of melanoma just from having so many moles.
Right.
It is more difficult to track those people when they come into the office. When I was in first year resident, I was like, oh my gosh, what do you even biopsy? There's so many things that don't look right. But thankfully there are, characteristics that we look for.
Okay.
Um, and
So
then
how do you diagnose it? Obviously, the skin exam is really the most important part. What do you look for?
Right. So, the skin exam, as you said, is extremely important. It can be done by patients themselves. In fact, we encourage our patients to look for these atypical moles on their body, kind of sort of weekly or monthly. We see these patients with increased risk factors twice a year or every 6
Okay.
months in our office for their full body skin examinations. So when they come to the office, we utilize a small diagnostic tool called a dermatoscope to magnify the mole so that we can see specific patterns and recognize some of these features of atypical moles or melanoma. It also helps us to guide our diagnostic criteria, I guess, and see if the biopsy would be warranted.
Okay. I have a question. I didn't ask you this before. At
Yeah.
what age should you start the skin exams?
That's a really good question. There's no hard and fast rule. A lot of the times we start seeing kids who are teenagers, especially, it's good to bring them in mainly for the education part of it.
Right.
Like tanning is bad. Use your sunscreen, don't go out and lay out in the sun. And then kind of following their moles, especially for these kids that have had a family history of melanoma or someone who has a lot of moles, or, the parents might be like, look, I'm seeing all these new moles that are popping up on my daughter. Would you be able to see them? And of course, we bring them in, but usually probably not until they're, tweens or teens.
Right. Because now my three daughters are at risk because of my husband's melanoma. So that does make you
Exactly.
wonder.
Right. And
Okay.
so in that case, we would recommend that you bring them all in and get a baseline skin exam so that we can
Okay.
follow them yearly.
Well, that's what they'll do this summer.
Sounds good.
Okay. So let's go over, I guess, the ABCDEs of melanoma, if you don't mind.
Yes, absolutely. So this is a really nice tool that we use in the office. And also, I really want patients to know this by heart because they can tell if something isn't right. Like you could tell that your husband's mole was abnormal.
Right.
So, I think most people have heard of it already. But in the next few slides, I'm going to go ahead and show you what atypical looks like. But before we go there, I wanted to talk about what a normal mole ideally should look like. It should be nice and smooth and round, even bordered, one color, and it can be bumpy or flat. And that's actually really important for people to know because more often than not, I would have somebody, kind of coming into the office really worried about their mole, and they're like, this is bumpy, it must be cancerous. But a lot of these bumpy moles are actually congenital nevi, and they tend to grow as a person ages and get bumpy. It doesn't mean that it's cancerous. So in terms of atypical moles, we'll go ahead and go to the next slide. So A stands for asymmetry. So if you cut it in half, the left side doesn't match the right side. B stands for border. So where the periphery of the mole is not smooth or round, but it could be jagged or uneven. C stands for color. So ideally a mole is light brown or dark brown, one color. When a mole starts to change, sometimes it's very hard for you to see. It's kind of subtle. The color starts to darken, or it can start to change color. A lot of the times, like in this case, you see that this particular mole, which actually turned out to be a melanoma, is red, brown, and black. But sometimes you can see other changes where the mole lightens and it turns into a bluish color or grayish or whitish color. And when we see gray and white, it's usually not a good sign, because it's a sign that the mole has been changing at some point and the body's immune system is actually attacking it. And that's a term we use called regression, which they look at in the pathology of a melanoma. So color is extremely important.
Yes.
And then D means diameter. So a normal mole is usually about the size of a pencil eraser, or even smaller. So when you have something that is bigger than that or getting bigger, it could be a cause for concern. And then finally, E stands for evolution. So a lesion that is changing in size or color, or sometimes a brand new mole that wasn't there before, that's, a sign of change. And also, this is, again, very important. If it shows any symptoms of inflammation, bleeding, scabbing, crusting, itching, those are things to definitely talk to your doctor about. We also look for what's called the ugly duckling. And I use this sign a lot because going back a few slides, we saw that patient that has tons of moles, and it's like, oh my gosh, what do I look for? Right. So sometimes in these kinds of patients, they have their signature moles. So a lot of their moles look like each other. So I don't need to biopsy those, because it's very unlikely that this person has 80 melanomas, right? Or 80 atypical nevi. So I look for the one that really jumps out at me, where I use my dermatoscope and I'm looking at it and going back to it. If I look at it more than 2 times with my dermatoscope, I'm going to biopsy it.
Right.
Because, it's like, might as well just do it, because those people, in that case, they do have a higher risk of melanoma anyway. So we would look for the ugly duckling sign.
Okay. My husband had an ugly duckling. That's what I
Yes,
saw.
absolutely.
Okay. So in doing the biopsy, what do you do, Dr. Gill?
Right. So a skin biopsy is very simple, and it takes like 5 or 10 minutes usually. We first numb the skin with lidocaine, which is injected into the skin. Takes just a minute or 2 to numb, and then we use a small flat blade, which is typically a shave biopsy, to either remove the entire mole if it's small, or a representative sample if the mole is big. And depending on the appearance of the lesion, sometimes we use a punch tool, which actually goes into the skin a little bit. It does require a stitch in that case. And occasionally, I would have a patient walk in and I know it's a melanoma and it's probably not a good one. And I would just numb them up right there, do an excisional surgery, take out the entire thing, sew it back up. And that's called an excisional biopsy. That's done depending on the situation.
Okay.
So the next slide actually shows you the drawing for an excisional biopsy. You can see that we don't take out a large margin or anything. The goal is to get the whole melanoma out, so that the pathologist can get more information for the diagnosis.
And then based on that pathology, you may have to go in and make a larger excisional
Exactly.
space, correct? Okay.
Exactly. Yeah, right. Exactly.
Okay, well, we can move on to how to protect ourselves from melanoma or any other skin cancer. And so we all love the sun. It's essential for vitamin D synthesis. It makes us feel better, but too much of anything is really not a good thing. And ultraviolet, radiation, there's 2 types mainly, UVA and UVB rays. The UVA rays, they can penetrate deeper into the skin, as the slide will show you. They can affect how you look. So you can look a little bit older, you age more readily when you're exposed to the sun, and it can also cause some hyperpigmentation. And some people do think it can lead to the formation of skin cancer. However, the UVB rays, they're the more dangerous rays. They can cause inflammation and sunburn and also pigment darkening, but they can also definitely lead to skin cancer. So we need to protect ourselves, and how we do that is through a bunch of things, but one in particular is sunscreen. And so SPF, can you tell me what SPF means and what it's all about?
Yes, of course.
Thank you.
So SPF stands for the sun protection factor, and you can see it on every single sunscreen bottle that's produced in the United States. And it basically measures the sunscreen's ability to protect you against a sunburn reaction. So the newest labeling has an FDA approval for the UVA and UVB, which is basically what's called broad spectrum. And in some bottles, on top of some bottles, they'll have a star rating as well for UVA, because actually UVA rays are the hardest to protect against with sunscreen.
Right.
So only certain chemicals can actually get at the entire UVA range, just because it's so broad. So generally, an SPF 15 means that if you apply the sunscreen correctly, you can stay out in the sun about 15 times longer without getting burned compared to your bare skin without the sunscreen. So, and I usually tell patients that the SPF provided refers to what happens under typical laboratory conditions. And in the real world, it's really what we're applying on our skin is not necessarily the same SPF as on the label. It's usually less. So, we don't recommend anything less than SPF 15. And a lot of patients say, oh, I wear sunscreen because it's in my makeup. Well, you better check the label, because
Right.
the makeup bottles don't typically have an SPF of 15 or higher. But we like just a baseline sunscreen application and then the makeup on top. And SPF 30 is what I typically recommend to patients.
Yes,
Oh,
I
and
do
the
as
other
well.
thing, yes, and the other thing is SPF is not additive. So patients often ask me, if they have SPF 15 in their foundation and then they apply an SPF 30 sunscreen, do they get an SPF of 45? No, it is not additive. It's
Definitely
actually
no.
the highest number that you actually apply. So,
Okay. So I think you and I both agree that it really should be anything above 30, 30
mhm,
and above.
yes.
Because I think you have told me in the past too that SPF 30 is really giving you double protection versus SPF 15 when it comes to sunburn, not anything else. Is that correct?
Well, so the SPF is very interesting. 15 and 30 are really the difference of several percentage points on the
Hmm.
spectrum of how much
Right.
you're actually getting burned. But I do know, if you are going to Hawaii and you're going to be surfing all day, a higher SPF is going to protect you significantly more than a lower SPF, just because number one, we're not necessarily applying sunscreen the way that it should be applied. We're not using as much as we should. Number two, environmental factors. Sunscreens are mostly chemical. There are some physical blockers out there, but if you're going to be out in the sun, in the water, that all gets degraded at some point. So you're still getting that sun. And one of my colleagues uses this phrase that, to kind of talk about sunscreen to patients. It's like, it's a filter, right? It's like smoking through a filtered cigarette. You're still getting the actual damage, but
Right.
just less. So the better filter you have, the
The better
better sun
protection.
protection.
But there still is some sun, you're getting sun, you're having some damage from the UV rays, that's for sure.
Exactly. But, it doesn't mean that you can't enjoy it. You just
No,
have to
we all like to
practice
be in the sun.
safe sun.
That's for
Right.
sure. I've been walking
Right.
every day since COVID started and I'm getting
Exactly.
a good bit of sun, but I wear my
Right.
sunblock every single time. So
Yes.
talking about sunblocks to buy, we should definitely buy ones that are broad spectrum. That's very important.
Mm-hmm.
And we want to try to buy them that are water and sweat resistant. That is very helpful as well. But when
Mm-hmm.
you're looking at the SPF factor, the SPF 15 absorbs about 93% of the UV radiation, SPF 30 about 97%, SPF 50 about 98%,
Mm-hmm.
and then SPF 100 99%. So you can see there's a marginal change as you go from 15 to 30 to 50 to 100. So you don't want to spend too much extra money on that 100 sunblock. If you're getting a 50, you should be okay. And it kind of is a little bit misleading when you think of that. You're just because you're getting SPF 100 or 110 doesn't mean you're getting extra protected and don't have to apply it as often. They all
Right.
should be applied in the same amount of time. And
Mm-hmm.
so we really should follow a simple rule when we're applying sunblock. I would say adopt a technique that you can use over and over again to not avoid skipped areas. You want to use a mirror in the beginning if you want to make sure you're getting in the right spots. If you're going to use sprays, you want to spray liberally, rub them in, not in the
Mm-hmm.
basically don't do it in the wind where it all goes off to the side and not on your body. And one of the slides we have here will show us that it's basically just following a teaspoon rule. If we're going to use cream type sunblocks, you're going to want to put a whole teaspoon on your face and neck, a teaspoon each on your chest and back, a teaspoon on your upper extremities, and a teaspoon, 2 teaspoons each on your lower extremities. That's kind of an easy rule to follow. And again, rub it in very nicely and try to adopt the same technique over and over. You want to put it on like 30 to 40, actually 15 to 30 minutes before you get out in the sun. And you want to, gosh, at least reapply it every 2 hours, but I would say even 60 to 90 minutes. Apply it as much as you can, especially even more if you're swimming or sweating a lot. Is there anything else you can do besides just using SPFs to help us?
Oh, absolutely. I mean, if you're out sunning, stay under an umbrella. And also don't forget to apply under your chin, because the sand reflects the sun's rays, and snow, if you're skiing, make
and
sure
water.
you're applying right, and water, all those things can reflect UV. And actually, more importantly, I think wearing protective clothing is so important, because it means that you don't have to be reapplying and getting yourself greasy. Because if you have that SPF or UPF 50 shirt on, it's on the whole day, or on as long as you're outside, and it's giving you lots of protection continuously. So I recommend, some protective clothing, hats and swim shirts. And, people might be confused by the UPF label, but basically a UPF just basically stands for the ultraviolet protection factor, when it's actually built into the fabric of clothing. And it indicates how effective the fabric is at blocking out UV light. So if you go to REI, go to any sporting goods store, you're going to find a lot of these products out there. And they typically have a UPF of 50. So I wouldn't go anything less than that. I would just, just a UPF 50 is probably, something you would get that offers the most benefit. So for comparison, if you get just a typical, white cotton t-shirt and you're out in the sun, it actually offers a UPF of only 7. And people often wear t-shirts into the water, into the ocean, thinking that it's going to give them protection. And when it gets wet, because of the weaving of the fabric, it drops to a UPF of 3. So don't wear that t-shirt into the water thinking that it's going to protect you.
It's not helping
really
you at all.
Exactly. And UPF is something that typically, doesn't degrade very easily unless you can see the shirt is like visibly, you can see holes through the shirt.
Right.
It can be enhanced by certain detergents like OxyClean. And if the shirt shrinks, and typically those fabrics don't really shrink, but if it does shrink, then the weaving is tighter. So you're actually getting a better
more protection.
Exactly.
Well, that's great. So the bottom line of this whole entire talk is we don't want melanoma or any other skin cancer. So we need to do a bunch of things about that. And that would be basically wearing our broad spectrum sunscreen, making sure it's at least a 30, I believe. And I believe you think that as well. Applying it 15 to 30 minutes before you go outside, and then reapplying it often, at least 60 to 90 minutes apart, and especially more if you are swimming or sweating. And then the UPF clothing, that's really important as well.
Yep.
Okay. Well, thank you guys so much for joining us on our presentation. This is Dr. Jing Gill of North Georgia Dermatology. I'm Dr. Christine Gould from Gynecology Associates of Gwinnett. And so just so you know, as May is Melanoma Awareness Month, it is important to wear sunscreen. Both of our practices do sell sunscreen in the office. I'm actually even offering a 30% discount right now for the month of May. So please enjoy yourselves, stay healthy from everything out there, and enjoy the sun, but do so safely.